Finals SAQ27, Diabetes mellitus and Tympanoplasty. The case. A 52-year-old man has been admitted for a tympanoplasty on the morning of surgery. He is a long-standing insulin-dependent diabetic who has failed to attend the preoperative assessment clinic. A. What specific issues does this patient's diabetes present? Issues include long-standing diabetes, now 52 years old. There is high probability of microvascular complications such as retinopathy, neuropathy, and nephropathy. There is increased probability of macrovascular complications such as ischemic heart disease and cerebrovascular disease. Next is failure to attend preoperative assessment. This may be indicative of generalized poor compliance with medical management and is associated with higher risk of complications of diabetes. There is a need to assess recent glucose control by checking HbA1c. HbA1c of more than 8.5% is associated with increased risk of postoperative complications. Non-urgent surgery should be cancelled and diabetes management be optimized. Patient has not had instructions on alteration of insulin regimen, hence increased risk of perioperative hypo or hyperglycemia. The patient may not have been staffed appropriately preoperatively, and this increases the risk of aspiration, especially if diabetic gastropathy is present. Thirdly, the patient is admitted on the morning of surgery. This leads to limited time for thorough assessment and investigation. However, there is a need to make a thorough assessment of symptoms and signs suggestive of serious vascular or renal comorbidity. If further investigations and assessment are indicated, non-urgent surgery should be postponed. B. How should his diabetes be managed while in the hospital? Introduction. Exogenous insulin is always required for patients who do not produce insulin in order to prevent catabolism, hyperglycemia, and ketosis. During times of stress such as surgery, release of pro-catabolic hormones exacerbate this situation further. Insulin may be given as an infusion or for short periods of starvation and minor surgery. The normal long-acting insulin dose may be relied upon. Regional anesthesia and opioids reduces catabolic hormone secretion, and this helps to improve metabolic management perioperatively. It is important to minimize starvation periods in diabetics, both pre- and post-operatively. The patient should be first on the morning or afternoon list. They should not be on the evening list as this is likely to lead to excessive starvation time. Monitor capillary blood glucose hourly if basal bolus insulin regimen and starvation time is short. Basal insulin provides continuous insulin release. Bolus is omitted with missed meals and then given when eating restarts. Glucose-containing fluids are to be avoided. If period of starvation is likely to be prolonged, i.e. more than one meal, or if the patient does not use a long-acting insulin, a variable rate intravenous insulin infusion regime must be commenced on admission in combination with glucose and potassium-containing fluid. When the patient is ready to eat post-operatively and is not suffering from nausea or vomiting, a pre-meal insulin bolus should be given at 30 to 60 minutes prior to discontinuation of the variable rate intravenous insulin infusion to avoid iatrogenic ketoacidosis. Capillary blood glucose target is 6 to 10 millimoles per liter. Up to 12 is acceptable for both regimens. Hourly capillary blood glucose monitoring for both regimens and if otherwise indicated. Aim to return to eating and mobilizing as soon as possible. Additional information. Perioperative management of insulin therapy when no more than one missed meal. If the patient is on the morning surgery list, always check blood glucose on admission. If the patient receives once daily insulin in the evening, reduce the dose night before by 20%. If the patient receives once a day insulin in the morning, reduce by 20% insulin dose on day before surgery and on day of surgery. If the patient receives one insulin injection twice a day, i.e. biphasic or ultra-long-acting, half the usual morning dose. If the patient receives 2 injections twice a day, i.e. short and intermediate-acting insulin, calculate total dose of morning insulin, give half as intermediate-acting only in the morning. If the patient receives 3 to 5 injections daily, basal bolus regimens, omit morning and lunchtime short-acting insulins, keep basal unchanged. For pre-mixed morning insulin, half the morning dose and omit the lunchtime dose. If the patient is listed for afternoon surgery and receives once a day insulin dose in the evening, reduce the night before dose by 20%. If the patient receives once a day insulin dose in the morning, reduce the dose by 20% on the day before surgery and on the day of surgery. If the patient receives one injection twice a day of biphasic or ultra-long-acting insulin, half the usual morning dose. If the patient receives 2 injections twice a day, i.e. short and intermediate acting insulin, calculate total dose of morning insulin and give half as intermediate acting only in the morning. If the patient receives 3 to 5 injections daily and is listed for afternoon surgery, give the usual morning insulin dose and omit the lunchtime dose. Next is perioperative management of oral diabetic medication when no more than one missed meal. If the patient is listed for morning surgery, for acarbose, omit morning dose if new by mouth. For meglitinide, omit morning dose if new by mouth. For metformin, take as normal, unless there is risk of lactic acidosis. For sulfonylureas, omit the morning dose, whether once daily or twice daily. For SGLT2 inhibitors, omit 24 hours prior to surgery. For pioglitazone, take as normal. For DDP4 inhibitors such as sitagliptin, take as normal. For GLP-1 analog such as exenatide and liraglutide, take as normal. If contrast medium is to be used, an estimated GFR is less than 50 mL per minute per 1.73 meters square, metformin should be omitted on the day of surgery and for the following 48 hours. If the patient is listed for afternoon surgery, for acarbose, give the morning dose if eating. For meglitinide, repaglinide, or nataglinide, give morning dose if eating. For metformin, take as normal unless contraindicated. For sulfonylureas, omit all. For SGLT2 inhibitors, omit. For pioglitazone, DDP4 inhibitors and GLP-1 analogs, take as normal. This table shows variable rate intravenous insulin infusion regime with blood glucose level and respective initial rate of insulin infusion and infusion rate if blood glucose is not less than 10 millimoles per liter. C. What are the anesthetic considerations for tympanoplasty? Tympanoplasty is a surgical technique to repair a defect in the tympanic membrane with the placement of a graft, either medial or lateral to the tympanic membrane annulus. Time of surgery 1 to 4 hours. Position is supine, head tilted to the side, with head ring and head up tilt. Blood loss is minimal. Preoperatively, check for CVS disease, as this will limit degree of hypotension possible. Oral pre-medication options include benzodiazepines, beta blockers, and clonidine. Assess for diabetic condition as mentioned previously. Intraoperative. Local or general anesthetic. Local anesthetic avoids loss of consciousness, which may make monitoring for hypoglycemia easier in the diabetic patient. If GA, south-facing ray tube or reinforced LMA is used. IPPV normally, especially if remifentanil infusion is used. Outline is often used. Ensure coughing is avoided during surgery. This may be achieved by local anesthetic spray to the larynx and neuromuscular blockade. However, if facial nerve monitoring is used, avoid neuromuscular blockade for nerve integrity monitoring. Ventilator advances means many ENT anesthetists favor spontaneous ventilation or pressure-supported spontaneous ventilation. This allows titration of analgesia and improves success for deep extubation techniques. Airway. Supraglottic airway device use depends on patient's characteristics. If the patient has long-standing diabetes and diabetic gastroparesis, this may make LMA inappropriate due to risk of aspiration. Head tilt may displace the airway. Surgeon close to the airway can displace, obstruct, or damage airway equipment, obscure the anesthetist's view of the patient, and limit access for anesthetist during operation. Structures around the head are inaccessible during surgery and requires protection, especially the eyes. Bloodless field. This enables greater surgical accuracy. Simple measures to achieve this includes potent opioid pre-induction, ensuring coughing is avoided, head-up tilt to reduce venous pressure. Hypotensive anesthesia is another option. This optimizes the surgical field, but this may be inappropriate in patients with long-standing diabetes, micro and macrovascular comorbidities. Remifentanil infusion is ideal to achieve hypotensive anesthesia. Usage of remifentanil commonly requires IPPV through either ETT or LMA. Beware of bradycardia and hypotension, especially in elderly and diabetic patients with autonomic neuropathy. To prevent post-op rebound hypertension and agitation, alternative analgesia such as longer-acting opioid should be given 15 to 20 minutes before the end of surgery. Other options include continuing remifentanil at low dose, clonidine or dexmedetomidine. Other methods to achieve hypotensive anesthesia includes IV labetalol, metoprolol, esmolol, vasodilators such as isoflurane and hydralazine. Arterial line is strongly advised. Head-up tilt reduces perfusion pressure to the brain and may cause cerebrovascular complications. Nitrous oxide should be avoided due to emetogenesis and gas diffusion into the middle ear, with potential for disruption of tympanoplasty graft. Optimization of ventilatory control. Low to normal EtCO2 avoids vasodilation and improves surgical bloodless field. Antiemesis. Give at least one antiemetic routinely, as middle ear surgery is associated with high risk of post-op nausea vomiting. Dexamethasone should be avoided in diabetes as it worsens blood sugar control. Tiva may be considered. In a diabetic patient, avoidance of nausea and vomiting is important in order to facilitate return to normal insulin regimen and diet. Deep or light extubation. Patients with long-standing diabetes may have gastropathy, and this may make deep extubation inappropriate due to risk of regurgitation and aspiration. Day case surgery. Tympanoplasty tends to be emetogenic. There is need for good analgesia and antiemesis in order to facilitate same-day discharge. Oral analgesia is usually sufficient for tympanoplasty. Options for analgesia includes paracetamol, NSAIDs or opioids unless contraindicated. NSAIDs may not be appropriate in diabetic patients with renal complications.